Bismillahirrahmanirrahim. Assalamu alaikum. While surfing through the net, I came across a MCQ and later on I found a SEQ related with an interesting topic. So I thought today we should talk about this one. So let's start our discussion. A patient presented with the following picture of tympanic membrane, most probable diagnosis. So in this picture, you can very clearly see that there are multiple perforations in the pars stanza. So the options given were tubercular otitis media, syphilitic otitis media, pseudomonas infection, and fungal otitis media. So multiple perforations is pathognomonic for tuberculous otitis media. So I thought we should talk about today tuberculous otitis media, which is highlighted with multiple perforations in the tympanic membrane. Please subscribe the channel so that you don't miss any future videos. And this was the SEQ, which I will analyze at the end of the session. A 39 years old female presented with history of copious amount of yellowish discharge on and off from left ear for the last 4 years, and there is a history of low grade fever, which is again intermittent with decreased hearing. Examination of the left ear shows multiple perforations. So this lady also has multiple perforations in the tympanic membrane, just like the MCQ we just talked about, and pale colored granulations, and then all those relevant questions: what is the diagnosis, investigations, and then what is the treatment. So let's talk about tuberculous otitis media. It is almost always secondary to pulmonary tuberculosis, though it used to be very common in children who were given non-pasteurized milk, but nowadays it is almost secondary to pulmonary tuberculosis. Usually children and young adults are affected. The infection reaches the middle ear cleft through the Eustachian tube usually, but still hematogenous or blood-borne infection spread can also be there, and this spread may be from other areas like tonsils or lymph nodes. Tuberculosis can affect the middle ear cleft as well, but as I said, it is almost always secondary to pulmonary tuberculosis. So usually pulmonary tuberculosis through the Eustachian tube, middle ear is affected. And in tuberculosis we know that there is tubercles formation, and these tubercle formations in the middle ear cleft, they are in the submucosal layers, and later on they caseate. Due to caseation they rupture and the tympanic membrane gives way, so there is multiple perforations of the tympanic membrane with painless creamy or yellowish color discharge. Granulations, if these are there, they will be pale granulations as compared to reddish granulations in case of atiquantral type of chronic suppurative otitis media, but it leads to caries of the spine, caries of the bones, and even ossicles are being necrosed, and then later on further complications can also occur like mastoiditis, fallopian canal. If it is necrosed, facial nerve will be exposed and facial nerve palsy may occur in tuberculous otitis media. Similarly, mastoiditis can lead to mastoid abscess, and then it can rupture, leading to post-auricular fistula, and osteomyelitis can lead to formation of bony sequestra. So clinical features will include painless ear discharge with multiple perforations. Hearing loss is disproportionate to the symptoms. Symptoms are not that much well marked, but hearing loss is too much, and even facial paralysis can occur in some cases. Investigations will include hematogenous investigations, then histopathological examinations, and radiological investigations. So routine CBC with ESR will be raised. In this case, Montu's test will be positive. Then ear discharge can be sent for Acer-Fos bacilli staining, that is AFB staining, or we can request for PCR for tuberculous bacilli. Sputum and ear discharge both should be sent for culture. Granulations, when removed, should be sent for histopathological examination. Chest X-ray is mandatory because it is almost always secondary to pulmonary tuberculosis. So the status of the lungs we must be aware of. So chest X-ray is mandatory, and then CT scan of the temporal bone to rule out the complications of tuberculous otitis media and to see the extent of the destruction caused by this tuberculosis of middle ear cleft. Mainstay of treatment is, of course, systemic anti-tubercular therapy. There are different regimes. Some people go for 6 months regime, some people favor 9 months regime. Medical people, pulmonologists, pediatricians, they will discuss with you in detail about these. There are different drugs. Some people again recommend that separate these drugs should be given, but when separately, if prescribed, then a huge amount of tablets patient has to take, so compliance is not that better. So some people are in favor of that combo of these drugs should be given in a single tablet form, so that compliance is better. It is easy for the patient to take the medicine, and usually if a combo of the drugs is available in the form of tablets, then 10 kg body weight is equal to 1 tablet. So for example, if your patient is 50 kg weight, then we can prescribe the combination of these drugs in tablet form, 5 tablets. So 1 tablet is equal to 10 kg body weight, and maximum 5 tablets you can prescribe. Along with, of course, you have to go for multivitamins, and these drugs, they have side effects as well. So baseline renal function tests, liver function tests, and eye examination is also mandatory. Then local treatment in the form of oral toilet, and topical antibiotics in the form of ear drops can be used, and in certain cases we may require mastoid surgery. The mastoid surgery will depend upon which particular operation we have to go for. It will depend upon the disease extent and its involvement. Sometimes we may have to go for only cortical mastectomy, especially in children, and in adults we may have to think about modified radical mastectomy. If bone has been eroded and sequestra of the bone are there, we have to remove all that dead bone. Or if complications already have occurred, of course we have to think about the modified radical mastectomy. But after surgery, the healing is delayed in these patients, and once the anti-tuberculous therapy is completed and any mastoid surgery, if required, has been done, so later on, according to the damage being caused by all these factors, we have to think about the reconstructive surgery, which may be in the form of ossiculoplasty, tympanoplasty, etc. So now coming back to that scenario with which I started the discussion, that the 39 years female presented with a history of copious amount of yellowish discharge from last 4 years. There is history of low grade fever off and on with decreased hearing. So adult patient presenting with hearing ear discharge, which is yellowish in color, and hearing loss with low grade on and off fever, and on examination there are multiple perforations in the tympanic membrane and pale colored granulations in the external auditory canal. So this is a typical presentation. Now by this discussion you may have a very clear idea, typical presentation of tuberculous otitis media, and relevant investigations and treatment we have already discussed. So if any queries in comment section, most welcome, and thanks for watching. Please share it with your friends and subscribe the channel. Thanks once again.